Welcome back, everybody. I'm Ann Snowdon, and we are delighted to welcome you to our inaugural Design Den. The concept of the Design Den was created for this year's design competition. Every year, as some of you may know, Scan Health partners with a health organization to identify a real supply chain challenge that they are looking for help with from the global marketplace to solve and to help work with them to overcome such a challenge. The design competition is a very unique knowledge mobilization strategy we designed specifically to create a safe environment where companies, entrepreneurs, innovators, academic teams, whoever they may be, to connect to and meaningfully demonstrate and show health systems struggling to find solutions, demonstrate what's possible and what kinds of solutions they maybe have already designed, developed, or could design to meet those challenges. This knowledge mobilization activity is really critical for two reasons. It helps industry much more deeply understand what are the challenges that health systems are facing and experiencing, so that they can then take that insider knowledge back into their innovative teams and create the solutions health systems actually really need and are very pragmatic and practical and can be implemented and scaled across health systems. The other outcome we're finding of this competition is health systems. Health systems have extraordinary demands on all of their time. No question, it's a complex environment that we work in, particularly now. Health systems don't always know and understand and can see some of these innovative solutions in the marketplace that could actually really solve some of their challenges. So in order to create a rich and robust learning environment between industry and health systems, we've incorporated something we're calling the Design Den into this year's competition. We were very grateful to have a world-renowned panel of judges that would adjudicate and evaluated all of the competition submissions based on very established and transparent criteria, determine the strength. Today, we are thrilled to have the two finalists enter the Design Den for all of you to learn from and participate and get a feel for what this Design Den competition experience was like for them. Each of the two teams will have 5 minutes to pitch their solution, followed by a Q&A period with selected judges that certainly brings lots of expertise in the areas of supply chain and health system digital transformation. But before we begin, it is an absolute honor for me to introduce you to our partners on this Design Den competition. Eastern Health, I think I mentioned this earlier, the largest integrated health system in Newfoundland and Labrador, Canada's easternmost province. And Next Generation Manufacturing, a not-for-profit organization that matches manufacturing excellence and expertise with new technologies, new opportunities to scale and to contribute to economic growth across Canada. So let me warmly welcome Ron Johnson, Vice President, Chief Information Officer of Eastern Health. Ron has been an incredibly important strategic partner for Scan Health for many years, but this year, front and center on the design competition. So Ron, over to you to share with us your views and your experience with this year's challenge.
Thank you, Anne. It's certainly been a pleasure to work with Scan Health on this competition. And as you've mentioned, Eastern Health is the largest integrated health organization in the province of Newfoundland and Labrador. We provide a full continuum of health services to a regional population of more than 300,000 people. And we're responsible for 7 unique provincial programs. With over 13,000 employees, we're certainly a very large academic health sciences organization, and we provide care all throughout the province. No doubt, the COVID-19 pandemic has highlighted significant supply chain challenges for all provincial health systems in Canada and the world for that matter. In that regard, we've identified a business challenge in determining product equivalency for personal protective equipment when sourcing products. As you're all aware, sourcing PPE has been a very significant challenge throughout this pandemic, throughout the world. And certainly we've been challenged in providing and procuring PPE to protect our workforce. As COVID-19 cases surged in Newfoundland and Labrador, it became much more difficult to secure PPE, and significant time and effort was put into that. The consistency, the completeness, and accuracy of the product and technical specifications was a key challenge for Eastern Health, and I suggest challenge for all jurisdictions. The problem was exacerbated by the lack of requirements for manufacturers to identify product attributes and technical specifications in a standardized and easily accessible manner to support health systems to understand equivalency. We certainly struggled with this throughout the event, especially when we were using suppliers that weren't our normal suppliers. You know, we've attempted to date to determine product equivalency, but we've been challenged by the lack of standards in descriptions of technical specs and product attributes that would enable any health system or team to establish equivalency. This design challenge was intended and is intended to find a solution that enables health systems to quickly recognize product equivalency in a consistent, accurate, and efficient manner. The primary objective of this design competition is to strengthen the global supply chain data quality and accuracy to support efficient and effective sourcing of PPE products. The solution must offer a standardized approach that enables the comparability of product data, both product attributes and technical specifications, currently held in system product registries or other data registries, such as GUDID, GDSN, and others, that include a mechanism for comparing and cross-referencing product data to determine the equivalency of products in the market without requiring significant investment in labor and laboratory testing by health systems procurement teams to determine product specifications and product performance. No doubt this was a challenge for all, and we're looking forward to responses for this competition. Thank you. We're very fortunate as well to have an incredible panel of judges to assist in determining successful teams and feasible solutions. In that regard, I am one of the judges, and I have a bunch of colleagues, including Mr. David M. Marcelleretti. He's the chair of our judging panel and vice chair of supply chain management with the Mayo Clinic. We also have Dr. Alex Mitchell, a general surgeon and senior medical director with the QE2 New Generation Project at the Nova Scotia Health Authority. We also have Dr. Jason Myers, CEO of the Next Generation Manufacturing Canada. We also have Mr. Rene Pickard, Vice President, Supply Chain Transformation, McKesson Canada. We also have Mr. Jitendra Prasad, Chief Program Officer of Contracting, Procurement, and Supply Management at Alberta Health Services. We also have Mr. Mike Schiller, Senior Director of Supply Chain at the Association for Healthcare Resource and Materials Management. We also have Mr. Altaf Stationwala, President and CEO, Mackenzie Health. I also like to introduce Dr. Natalia Wilson, adjunct faculty member, Arizona State University, and Mr. Steve Retling, Chief Technology and Innovation Officer at HIMSS. It's also my pleasure to introduce the first semi-finalist team to join us in the Design Den. The team is a collaborative effort between industry, healthcare, and academia. Their solution is called DEFUSE, which stands for Deep Learning Empowered Supply Chain Risk Management for the healthcare system. Joining us today are Dr. Ranley Bradley, Associate Professor of Information Systems and Supply Chain Management at the Haslam College of Business, University of Tennessee, Knoxville. We also have Mr. Jeremy Johnson, Director of Supply Chain Management at Southeast Health in Alabama, United States, and Dr. Yi Shi, Lead Research Scientist at Intelligent Automation, Inc. Dr. Bradley will provide an overview of the DEFUSE solution.
Hi everyone, I'm Randy Bradley representing Team DEFUSE. And today what I want to do is present to you our solution to address the challenges and issues raised by Eastern Health, but issues that are also faced by so many health systems around the world. So before I jump into the solution, let me present our team. We have a multi-stakeholder team, myself representing the academic partner, my colleagues from Southeast Health who serve as our health system partner, and then the key behind this particular solution we propose, which is Intelligent Automations Incorporated, who serve as our technology solution provider. And so with respect to this, there are a number of things that we'd like to point out here that Eastern Health brought to the forefront in terms of the challenges that they were facing with respect to COVID-19. COVID-19 has impacted every aspect of our ecosystem, from patients to distributors to manufacturers, even with respect to having payers scrambling to try to figure out how we're going to deal with this. This is not an isolated issue that affects only a single payer system, but it also affects multi-payer health systems as well. And so when it comes to PPE, how do we ensure that when supplies run short, that we can identify the appropriate equivalent products, and then most importantly, ensure that once we've identified the equivalent product, that we can actually find it? And so there are a number of healthcare challenges that were brought about, and supply chain challenges that were brought about by Eastern Health, not to mention these 4 here on the screen. So how do we address these while at the same time tackling and battling these 5 pervasive supply chain challenges across the globe, trying to improve supply chain risk visibility and mitigation techniques, harnessing data, valuable data from a very disparate sources that provide multiple sources of truth, and also proactively approaching to ensure that we have equilibrium between supply and demand? Well, welcome and introduce DEFUSE. DEFUSE is a product that is based on the latest and the greatest technology around artificial intelligence. And we don't just use artificial intelligence as a buzzword. Artificial intelligence, and particularly feed-forward neural networks, are at the core of what we propose. And what it enables us to do, it enables us to hone in on a particular product of interest of a health system, show them comparable products by comparing various product data, by leveraging data from manufacturers, leveraging data from data repositories, leveraging data from government and state entities to allow us to say, is this an equivalent match? And not only will we, in this case, begin to show an organization, here's a potential equivalent, we will show them the percentage of confidence that the DEFUSE system has in that product being an equivalent match. And what happens is now those clinicians, as well as those supply chain professionals, as well as those individuals who work in quality or in pharmacy, are on their way to making improved decisions more efficiently and faster. And so by way of several other things that we do, we're able to scale this regardless of the size of the health system, regardless of whether you want to look at this across a province or across the nation. DEFUSE is absolutely scalable to be able to address those issues no matter how they're presented. How do we do this? What we do is we aggregate data across at least 9 categories and extract data from more than 50 sources, not including those local sources of data that the health system would actually have. And then with respect to that, we give each health system the ability to fine-tune the frequency in which we can pull that data. Granted, some of that is dictated by the source where we pull it from, but every health system will have the flexibility to determine how up to date they want that data to be. How do we handle conflicts and reconcile that data? Well, that's pretty straightforward. What we do, because we use a variety of artificial intelligence, not just feed-forward neural networks, but recurrent neural networks. And we use sometimes long and short-term memory. And what that does is allow us to ascertain the reason for the data inconsistency or data integrity issues. And then based on that, DEFUSE will appropriate and leverage the appropriate analytics mechanism to help reconcile that data to ensure that at any given point in time, that health system can have a high level of degree of confidence. Let's take this one particular case study here. An organization trying to identify a comparable product here. Not only do we show them a list of products, but we also let them know the potential risk level for that product not being able to supply. And then we don't just leave you there if you're a supply chain professional. We take you one step farther where we begin to show you what's the reason why that particular product is at a high risk for not being supplied. And then in addition to that, we allow you to do what if analysis, change this, change that, and see what impact it actually has. So having said this, you can see DEFUSE uses state-of-the-art characteristics based on leading industry and academic practices to identify the most important components of risk, and then put forth an easily and seamless solution that can be used by any particular professional, whether you're a novice or whether you're extremely experienced, whether you're in supply chain or whether you're a clinician. DEFUSE is the right solution for you. We look forward to your questions.
Thank you so much, DEFUSE team and Randy Bradley. We can open the session to questions. Perhaps Dave, would you like to kick off the questions and we can proceed from there?
Yeah. Sorry again for my technical difficulties. My goodness. Can you? Thank you for that presentation. The audio was excellent. Can you speak a little bit about your data sources and how that's processed and cleansed on the way in to build all those attributes for the materials in that product information management system?
Yeah, absolutely. And thank you very much for the question, Dave. As we highlighted in this particular segment, when we talk about sort of those 9 categories, we're looking at local data that's provided by the health systems, and that can be a variety of things. It could be data from their MMIS solution. It could also be data where they capture the utilization of various supplies and resources. In addition to that, we also pull from national registries. So we also pull from the documents that manufacturers would have submitted to ensure that their products are authorized for use, whether they're COVID specific or even if they're not COVID specific. We also access the GDSN, so the Global Data Synchronization Network, as well as the Global Unique Device Identification Database from the FDA. In addition to that, we have the ability to tie into distributor systems that each health system is utilizing to extract products that we know these individuals have contracted for already, and then any external facing solutions that manufacturers or OEMs have relative to those products, we have the ability to extract that information as well. And that's just from a product standpoint. From a risk standpoint, we utilize public and state and federal entities where we can identify what are the social and business activities of a manufacturer as well as a distributor, so that we can identify not only are there potential risks with respect to the product, but whether there are changes in the organizational mechanism that would impact the ability to produce those products or satisfy any assurance of supply claims. So we look at legal documentation, we look at job search features, we also look at whether there's turnover and change with respect to key personnel in those organizations. And we don't just look at a record level. We analyze the data at an element level, so that even if there's conflict across solution systems, we can take the most accurate element to piece together a complete record.
Well, thank you. That answered the question.
Thank you, Dave. Other questions?
I have a question.
Yes, Alex, over to you.
Thanks. Randy, one of the, I think at the front line, one of the experiences is not just what organizations or the regulators or the manufacturers have experienced, but a way to compile those who get the, the first series of product that's poor. I think connecting the actual use sites so that when we get a box from this particular distributor that contains a bunch of, crap, that there's an opportunity for us to enter that data and have all our partners say, oh crap, we were about to sign a contract and buy that same crap in 2 weeks. We won't, because now our partner has experienced this challenge. Is there a way in which your platform would compile the actual frontline experience so that there's a little bit of, social justice here? We combine all of our knowledge together.
Yes, Alex, that's a very good point and realistic, and I'll answer, and then I'm going to let Jeremy Johnson come in and talk about an issue in their organization that we actually work through as a use case here. So absolutely, one of the things that we build into the solution is the ability for every site that's utilizing a particular product to begin to score the quality of that product or the performance of whoever was responsible for disseminating that. In addition to that, we also leverage social media streams, whether they're at a health system level or whether they're just at the general consumer level, to be able to aggregate that information. And again, given the time we have, we can't distill all the sources here, but I think you'll see in the proposal where we lay out a pretty definitive source, but that social justice aspect of it is extremely vital. In addition to that, if you're a multi-hospital health system or an integrated delivery network, we also appropriate the opportunity to not only understand what's happening at each site, but also looking at utilization and burn rate and giving you visibility across those facilities, so that now you can determine whether or not you need to move or shuffle products within the network. Whereas right now, most health systems just don't have the ability to do that. And one thing we forgot to mention that makes this possible, our solution is technologically agnostic. We don't really care what vendors any health system is using, whether from the EMR or from the ERP. It doesn't really matter to us. We're built on an open architecture environment such that if there are APIs available or if there's a willingness to allow us to push and pull, we have the ability to tap into that. So Jeremy, I'll toss it over to you to talk a little bit about that issue at your org. I think you're muted.
Jeremy, can you unmute?
Yeah, there we
There
go.
you go.
Can you hear me all right now?
Yep.
So, technology is a two-edged sword, right? So, and
Yeah.
back to your question, I was just in a meeting yesterday, and what you just mentioned in that question, and inside my mind, I look around as running the supply chain here with the team, and I look around and wonder, is that product equivalent? And I asked the CEO and the CFO, do you realize that's going through our hearts? We're compassionate in supply chain, but we have to make quick decisions. The thing is, though, our return on investment is visibility, right? And so, but yet visibility is such a broad term. It takes us down various journeys. And so what I like to do with DEFUSE is incorporate the what if analysis, right? And that prevents what we call it paralysis by analysis. And that happens very quickly. And so we kind of get stuck. So what I like through our use case was our N95 mask. I do have masks that are stored over here and over there, and we can't use them. And that's because we had to do a little bit of impulse buying. We didn't see product equivalency. And so we need to tap into those other industries. And so with DEFUSE, we were able to do that. And so at the legwork, and it's amazing what they do. Now it's a little bit over my head, but the algorithms and the neural networks, they can explain that. But we don't necessarily care about that. We care about that because it's going to end up with our patient, right? The product's going to end up with our patient. And so I call it simple funneling, how it just comes through. And I'm able to view very quickly and easily some substitutes and some comparable products. So that way, when I do push the button, I don't get I guess you call it the crap, right? And so that stuff right there is just, and it goes through our minds every day, again, when I'm looking at our nurses and our doctors and wondering if that product is equivalent. So this takes everything into perspective in the simple funnel that I mentioned and encompasses the supply chain risk and vulnerabilities that we have up front. And I can sleep a little bit better at night knowing that I did at least a few use cases with DEFUSE. Anything else anybody wanted to add to that?
Thank you, Jeremy. Maybe we'll go to our next question. Jay.
Maybe it's sorry, go ahead. Sorry, Renee. Go ahead, Jay. I'll go after. It's fine.
Sorry about that. We'll go Jay and then Renee.
We're just all piling in here with questions. Thanks.
Yeah, fantastic.
Very much for the presentation. I really appreciate the whole supply chain approach here. I guess my question is more kind of looking at future development of the platform and future opportunities of what you are able to do, and particularly with respect to this challenge of equivalency of standards. If you had an opportunity to grow and improve the platform, how would you do that? What would you do? What would your priorities be in terms of improvements of what you're doing right now?
Yeah, Jay, that's an excellent question, and we have given some thought to sort of what that maturation pathway would look like. One of the things that we believe that's going to be extremely pertinent is right now the focus is around PPE as a result of COVID. But if we begin to pull back the curtain, we begin to realize the issue with COVID isn't just PPE. It's really far stretching across the health systems. And so I would say this, in terms of modification, we would likely be able to pull into really more of the European databases. I know we allude to one database in Australia that we vetted, but there are some other databases out there that have identifications that we really need to pull in to be able to cater to global health systems to make sure the solution is even more scalable. The other part that we would do is we would probably make the risk aspect a bit more robust. And what I mean by that is what we focus on were really 7 primary categories of risk that every organization needs to focus on. Well, there's more than 7 categories. Those are just the 7 that are really most pertinent. So I can see where we would actually begin to expand it beyond that. And the what if analysis that Jeremy talked about is to be able to make that a little more interactive so that from a user standpoint, any user, regardless of their skill set, will have a level of confidence. If I'm a physician and I'm trying to figure out, you know what, I'm typically using this particular implant on this type of patient. And yet the guys in supply chain have been on me in quality saying, what do we get some product rationalization and standardization? And I really don't know what all that means. But if they giving them the ability to go into DEFUSE, enter just the product name, product description, product ID, and along those lines, pulling back comparable products that have nothing to do with PPE, but really look across the services being rendered in that facility, and giving that physician the evidence that he or she would need to feel more confident when they do some type of product or SKU rationalization. Those are areas where I can really see us easily going. The other part is more closely integrating this with the enterprise relationship planning solutions that facilities have, so that it's not just a pass-through, but really there is this level of embeddedness, and we can move away from talking about interoperability and actually starting to do and have interoperability.
Thank
Great.
you. And we'll go to Renee, and then I'll come to Alta.
Randy, I guess I'm talking to you from a wholesaler point of view. So inside your inside what are you also giving us capacities to manufacturers that you're working with, or the information, or is there capacity or of the product, or what is available, or what the manufacturer has as capacity?
So Renee, I'm going to repeat your question to make sure I'm understanding it. Are you asking me, is the operational capacity visible to the health system, or are you asking me, is the information being passed back over to a wholesaler or distributor?
No. So inside what you are servicing, so what you're offering today, so you're the system. So if I'm looking at the alternatives that you can have, is there also a visibility of what capacity that they have on that alternative? Because technically we want to go fast, right? So things need to go fast when you need that alternative. So
right.
So how are you helping us to go fast?
The only way we can help you go fast is if you have that visibility, whether it's through your distributor or wholesaler. And oftentimes they have third-party solutions that most health systems are using to get that visibility. We do have the ability to pull that into DEFUSE, so that when we offer you or recommend an equivalent product, we can also show you what was available at the most recent refresh. And with respect to that availability, we try to refresh the utilization data every hour, so that we not only know what you have, we know the rate at which you're going through it, which then allows you to take into consideration what your lead time is relative to trying to replenish that, so that we don't show you something that you actually can't get. The other piece of that, Renee, that you didn't really ask about, but I'll highlight here, which is this: just because we believe an organization has the capacity to produce doesn't necessarily mean they have the wherewithal to follow through. And that's where searching those external factors about the organization, their performance, their dynamics, their structure, allows us to give you, with every product we show you, we're going to show you two things. We're going to show you an equivalency match, and then we're also going to show you a risk score. And that risk score tells you the likelihood that you're not going to be able to get that product. If it's high risk, we're saying, you know what, it's an equivalent product, but you're not likely to get it for a variety of reasons. A clinician doesn't really care what the reasons are. Someone in supply chain does want to know why they can't get it. So we then allow them to drill down with respect to that risk, and then we show them every component of the risk algorithm that led to us rating it as a high risk, and tell them what and why, and then also giving them the opportunity to say, to address this risk, you can make this change. And in making that change, they can then see the respective modification to that risk score and that risk profile based on decisions they're making. So in terms of going fast, we help you go fast, but we help you to go fast better.
Well, Randy, thank you. Great presentation. I just want to go back to a previous discussion around sort of future state and the modeling and interfacing with electronic medical records as well. So in advanced EMRs, we're able to create product bundles. So X patient will require these many line items of product, and you can kind of model burn rates, not as individual items, but as a package, almost like an order set.
Right.
So do you have that ability so that I can actually, in a forecasting way, say, if I have another 30 ICU COVID patients or another 30 GIM ICU COVID patients, this is the sort of bundle I'm going to need, and this is the forecasting burn rate. So can you create that kind of interface with the EMRs so that we have some predictive analytics as well?
Yeah, I'll talk. That's a great question. In fact, and I'm going to answer and then toss it back to Jeremy, because one of the use cases that we worked through at his facility was pertaining to the PIVs. And with respect to that, as you imagine, you have those starter kits and there are various components. But when you go to a distributor to actually get that, what they're going to tell you is this order is rejected. And you don't know why it's rejected until you drill down, and then it turns out it's rejected because only one of those components can't be supplied. And so, yes, we do have the ability to take a solution that you bundle together, extract the components, and then assess the risk level relative to each particular component. And if there is, in fact, a comparable product that can be substituted, we'll show you what can be substituted relative to that kit so as to not negatively impact the efficacy of the solution. So Jeremy, I'll toss it over to you to talk a little bit more about that.
Yeah, real quickly. So for this call, you know, just to kind of keep this in very detailed manner for everyone to understand, we did a conversion. So we just went live with a new ERP. We decided to go live with an EMR. All at the same time, we invited COVID in. We've got a few hurricanes and tornadoes out there as well. So what we've done is we decided to add one more thing. Let's do a conversion. And so it was for PICC lines, anything IV related through the whole organization. That's culture shock, behavior change, you know, the whole gamut. And so instead of, we had what we needed, but what happened at the tail end was a component was missing. So we were doing manual processes. And so when we take the PIV catheters and you have the 5 or 6 components you need for the procedure, that one component can disrupt patient care. And so with DEFUSE, it can redirect us to a product that we can utilize. And it happened to us. And it happened before I linked up with this team. And so that's why I'm so compassionate about why we need to implement this and share this with all the hospitals across the globe. The industry is moving so fast, but we have that patient there. And so when we were able to take that component, when you look at the component and you know it's missing, you know that something's wrong. Something's going to happen and the physicians are going to hear about it, right? And we can't, there's going to be a different patient outcome, right? We know that. So how can we prevent that? And so with DEFUSE, we're able to look at the different substitutes and the components and bundle that together. Absolutely, yes. And again, you can tell I'm real compassionate about it because it was so fast and so moving for us. When the component was missing, we had to go back to the vendor because the distributor couldn't, they overpromised and underdelivered. That's what they did. But we were able at the end of the day, and I'd like to share this with all of you, get that product in the door. Now, that was a manual process. If I'm doing this multiple times with multiple procedures and multiple different cases throughout a hospital, I mean, it's a lot. It's a lot for large IDNs and just smaller hospitals. The thing I like also about DEFUSE is what Dr. Bradley just mentioned about the analysis across an IDN. So that way I can visually look at some of my peer hospital groups and work and collaborate with them as well. And so that's what's nice about that feature. And you'll see it on the graph later on the slide deck.
Thank you so much, Randy and Jeremy. We are almost out of time, but I know we had some delays early on. Are there any other items or questions the judging panel would like to ask or the team would like to add just before we close off?
I just wanted to follow up on, I think it was Renee's question and answer session. With that risk register that you're doing, does that take into account allocations? Because one of the issues we've all had is you need a substitute gown because you can't get the Amy gown that you need, but the manufacturer, which is a viable sub, you can't get it either. Does that allocation kind of lend itself to the capacity or risk register that you talked about? I imagine it would, right?
Yeah, David, it has the ability to do that. One of the things that we say is when we release the solution, there are these built-in elements that we consider in terms of risk. However, with respect to each facility, there are things that are unique to them that they would like to consider. We have the ability to add those into the risk algorithm. So that's absolutely possible.
Yeah, that's great. Yep, thank you. And again, sorry, I was scrambling to find a network cable.
It's okay, Dave. I never found the network cable and I was in the same boat. With that, I don't think we have any other pressing questions to ask among the judges or the team. Let me wrap up our session today and thank everybody for their time.
Thank you for that insightful solution, Team DEFUSE. Our next pitch is a collaboration between a solution provider and a health system partner. From Symmetric Health Solutions, I would like to welcome Mr. John Borner, CTO, Mr. Thomas Dardet, CMO, Mr. Ryan Kissel, COO, Mr. Rich Kusira, CEO, and from the Resource Group, a subsidiary of Ascension, we have Mr. Matt Stone, Vice President, Operations, Data, and Supply Resiliency. Mr. Rich Kusira will now provide an overview of the Symmetric Health Solution.
Hello, everyone. My name is Rich Kusira. I'm the CEO and one of the co-founders at Symmetric Health Solutions. I appreciate your time and consideration reviewing our submission and look forward to answering any questions you may have, as well as any feedback you have on improving our solution or our approach to solving this really critical challenge facing the healthcare supply chain. Symmetric Health Solutions is a data and analytics software company for healthcare providers to cleanse, enrich, and analyze their medical supplies data sets. When I use the term medical supplies, I mean everything from patient slippers, isolation gowns, N95 masks, to pharmaceuticals, lab diagnostics, and even equipment like ventilators. Each night, we pull from over 100 data sources to create over 400 attributes on supplies, as well as suppliers and their relationship to distributors. The data that we're pulling includes everything from approval and clearance documents to instructions and technical specifications, as well as discrete data. So it's both structured and unstructured. All of our fields we are creating are discrete fields about the item. Some of these fields include different sizes by category and clinically relevant sizes, to really critical operations flags like whether it's implantable, bioabsorbable, sterile or non-sterile, latex or free, but also includes information such as where it's manufactured, where it's imported, where it was sterilized or reprocessed, to really start solving a lot of the challenges in healthcare operations using data that previously wasn't available. We use quite a bit of new technology, including machine learning, natural language processing, and even OCR to read some of these different approval and clearance documents and extract really useful information, both for the healthcare supply chain professionals as well as clinicians themselves. So we pull all this information every night, and then for the hospitals, we match and align it to their item universe so that they can use both the attributes internally as well as start to see what they're purchasing and what other options are available for alternatives. This has been something very core to our vision and mission of the company, was to set the bar really at, do we know enough information about an item? We should be able to predict a clinically relevant substitute. And so that's how we focused on all of our data pipelines, algorithms, and why we've built out such a breadth of information about each item. We also recognize that creating this source of truth and adding all this information requires immense user feedback. And how do you get at that in a value-added activity? Well, prior to COVID, we thought of this through standardization. So looking at the really cost per case and what items are substitutable with other items being purchased at a facility or even within a system. So we have within our web application a workflow for anyone to go through and say whether something looks substitutable, and then to go through again with a clinician and identify as clinically substitutable to move forward with. Well, capturing this, we can share it each night since we're refreshing both our data sets as well as all of the customers' data sets aligned to ours to provide these insights to other customers. Additionally, we're using that to improve our algorithms for identifying alternatives, as well as seeing by category in the data, are there features or key pieces of information we're missing? Is there something about this item that we don't know yet? Last thing I would like to add, and this was pretty critical again from the beginning of our company, was to make sure our solution worked for any type of hospital. I'm happy to say that we're at over 200 acute care facilities, and our customers represent rural community health systems to academic medical centers, regional health systems, and even large multi-state IDNs. Everyone is using our solution with different levels of integration. So starting this entire process could be as simple as logging on to our cloud application, uploading a supplies file dataset of any size, and then going through the different workflows like back orders, standardization, substitutes, or pulling down reports such as what's manufactured in China that I should be concerned with in terms of receiving based off of my current inventory levels. Again, thank you for your time today, and I look forward to answering any questions and receiving any feedback you may have. Thank you.
Can you speak a little bit about the source of manufacturing. We have a team for continuity here at Mayo, and we find that there is no magic bullet around manufacturing location, and getting that data for most of what we buy is very difficult. And when you do get the information from your suppliers, it is a bit of a moving target, because there's multiple sources of raw materials constantly moving and changing, multiple sources of finished good procurement that's constantly changing. Can you just, where do you get that data, and how is it always up to date?
Yeah. Can you hear me?
Yes.
Okay. Yeah, so it's not like the bill of materials and where the raw materials are sourced. So we use, are you familiar with the FDA's registration listings? So we spend quite a bit of time mapping those. We feel that's a fairly reliable source, both from our research and from the fact that manufacturers are required to update it each year. Some pieces of that are easier to map than others, and we use quite different techniques to match those data sets to each of the items. I'm happy to go in more detail about that, but a big piece of it's around the approval clearance documents, as well as the categorization within the FDAs, and understanding what items are there and what other categories they've put elsewhere. So,
hey, Rich, this is Mike Schiller. Thanks for your presentation. You talk about pulling from 100+ data sources. These are all public data sources, correct?
Correct.
So can you talk us through how you're validating the accuracy of these public data sources? And then a little bit more specifically around how the data sources lead to clinically acceptable substitutes.
Yeah. So one of the reasons we're pulling from all these different data sources is to use the information to see where things misalign. So there's discrepancies. It's hard to know what's wrong in a data set past like the basic data validation steps. After that, once you get into like a category, how do you know what's wrong? Well, parts of ways to do that is to pull in more information about the item and see where things misalign. In terms of whether or not these are substitutable, I believe everyone will read our 70-page solution document after this that has links to quite a few videos. But there's like 3 ways in which we are tackling this problem. So first and foremost, we started with who else has already reviewed substitutable products. And I believe I spoke in the last year's competition about this. The FDA's 510K process was our starting grounds. We built a graph database relating the 510K predicate chain back to the beginning of time that showed, and for those unfamiliar, it's a clearance process at the FDA where something is, if it's substantially equivalent, then you don't need to go through a more rigorous approval process. So that's one thing that we pull every night. So we map those predicates on those documents tied to individual items back and have relationships for those. We then added all the attributes about the item. So starting to understand well, what is happening in the 510K process. So this is just one piece of it, and really how we started tackling the problem. What we started to see was we could actually identify what were kits and systems and different things, and this was a part, and this other part from those documents, which was pretty exciting. So from that, we learned a lot, and we also started to learn by category what we needed to know and what attributes we needed to build out. So ultimately, we wouldn't need to do a lot of these things if we knew everything about the item, which is kind of what I was getting at in the pitch. So while we continue to add attributes, and we think there's thousands, to be honest, that are needed eventually, but we can start getting pretty close with a couple hundred or 400 we're at. The last thing is user feedback and really iterating very quickly off that. So if we know a clinician says something is substitutable somewhere, we can validate that. That's tagged data that we can use in our algorithms elsewhere, and we can do that overnight. So something that's really core to everything we're also doing is we realize to get this all accurate and up to date for everyone, it's how fast can you iterate on your data set and what you know. So those are kind of the three main ways in which we try to tackle that problem. That's pretty difficult.
Thanks, Rich.
So, Rich, may I ask a question? It's Altaf here. So I'm just trying to understand your database tool, and from the end user's perspective, what the workflow would look like from the manufacturer to the distributor, to the warehouse, to the dock, and then to the ultimate sort of end user using products that are in the database, or even some of the substitution algorithms that you talk about. How would it work?
Yeah, so we have videos of the application in the document we submit, so you can and screenshots that walk you through. So if you're at a hospital and you have, let's say, your purchase order data or your item master, once you've uploaded that into the web application, you go through a matching process, and it's like a supervised learning process that allows you to basically have all the attributes and all the information we know about our items and our data universe to your items. And so then you can start going through and seeing, like, you can search your items, click substitutes, see multiple substitutes, and do comparisons on items. If that's, yeah.
Sorry, it was more about the validity of the supply chain from the source to what we're viewing. So your assumption is that whatever you've put in the database is accurate, and we have to assume that everything is authentic that's come in from the very beginning. Then that's the assumption, I guess.
So yeah, we have all our data sources available. A big piece of it is regulatory data that people are required to keep up to date, and that's been a big focus of ours, as well as all the user feedback we've gotten on the data. So I guess one thing to add is at any point in the application, you can, if you see something inaccurate, you can edit that, and then we know as well as everyone else knows. So there's an entire section on feedback, but yeah, it's as valid as all the data sources we're pulling from and all the feedback that we've received.
And this is Tomas, just to kind of add a little bit to that answer. One, during that matching process that Rich described, after that happens, there's a reporting section within our application for item master data quality. And effectively what that's actually doing at any point in time is it's comparing two data sets. In this case, our latest master data set and whatever the hospital thinks is true, and flagging any case where there's a particular field that there's a disagreement on. That is then presented to users as, hey, there's a potential disagreement here that needs an investigation. And we do both internal investigation in bulk to help our users, and we write a couple different algorithms to basically just a lot of data quality checks to apply anything that we've learned, as well as do research sessions on those data attributes that are mismatching. So what you can do is you could think of as we grow, if we were to get distributors and manufacturers as well as customers, they could upload their data sets and at any point in time compare between two views of the same information, continuously improving that data quality. So that was one piece that I wanted to kind of add there.
Jay Myers here. I want to thank you for the presentation as well. I have three quick questions and for you guys, and sorry, here the first is very specific, and that's about how do you handle packaging. The second is a little bit more broader, and it's I wanted to get your feedback about some of the response from the clinicians themselves in terms of what how they have found the system helping them in finding substitutes that do work. And the third, being based in Canada, is a question about whether you work with other certification bodies and testing organizations, because I think a part of the issue here is to find alternatives that may actually not have gone through currently some of the testing procedures, or finding alternatives to the testing or other certification, make sure that they can be certified to other types of standards that have been set by other national healthcare certifying bodies.
Yeah. I'll start with the packaging question. So we group all packaging. So there's actually an entire section on packaging in what we submitted. So I'm glad we included that. There's multiple ways in which we format packaging and to align that based off of the different common systems. We think we've covered basically any variation of how you would store and identify packaging at this point. Some of the things we do around barcoding with that is if there are duplicates or historical or multiple issuing agencies, those are grouped into the packaging that's being loaded. So that really you could scan both any level or any barcode on the item. And then lastly, you'll see we've moved into actually recognizing the labels in inventory. And that is a big piece of feedback into the packaging that we're excited to start using. I believe your second question was Canada accreditation, and so we aren't in Canada yet. Maybe I use yet little, but we do pull a lot of Canadian data from the Open Canada, so AMDAL and whatnot. I'm not sure if that's exactly the type of question you were asking, but those would not, we have seen many items that have not gone through, let's say like the US FDA's process. But the reason we pull it, even though we're in the US, is we see items in that data set in the US that are not cleared or approved in the US prior to even this pandemic.
Yeah, I guess my question was about how you see your solution helping to improve the recognition of, I guess, capability based standards across different types of product lines that could be recognized by various testing or certification bodies.
Yeah, so I think the one thing to it's also in the document that is, and perhaps this is what you're getting at. We pulled also like NIOSH and other, is that kind of what you're asking? Other accreditations and specifications pretty early on. So we started adding those data sets to our data pipelines in about March and April timeframe. And we expanded globally pretty quickly with those data sets and those approvals and clearance by different organizations that are more common in, let's say, like the oil and gas industry and for PPE related items. So yeah, we did start pulling that in. We did see, I think what you're also getting at is in comparing those, some breakages between what one body's saying and what another body's saying. And so, yeah, we did identify those as well. Yeah, and then I think the last thing on clinical feedback and like usefulness, so for first and foremost was, I think even early on, was resolving backwards and having like a list of items to actually go off of and look at and bring back to a clinician when it was a serious item that was back ordered. We got a lot of thumbs up on the ability to do that and do it quickly. One thing we're also working on is really making the understanding of items, like their descriptions, very clinically friendly so that they can read it in an organized fashion much quicker. And that's really because the reason we can do that and how we're doing it is because we're building all these attributes. So we can organize things categorically and put it in a structure that is perhaps more, or what we think is more human readable, as well as more predictable for someone reading description. And they don't look like the descriptions that we're used to in supply chain.
Great, thanks.
All right, it's Rene Picard. Just so I work for a wholesale company. So the question for you is does the tool also permit us to see capacity from the manufacturers? So what type of capacity that they have to be able to supply? Because question for us. So available capacity and what types of capacity that they have?
Yeah, we're not there yet. That would require more collaboration from the manufacturers and distributors, and but that's definitely something we could work on. Part of the reason our company's name is Symmetric is we really thought we could get feedback between all the different bodies and data sets as we grew. So I think TJ alluded to that in terms of data quality between the different bodies, and we think of that beyond just manufacturers, distributors, and buyers like the hospitals, but also like regulatory bodies, standards bodies. So, and perhaps in a similar vein of making better data quality information like that could be shared.
All right, I have a quick question. So this all sounds good about the hundreds of attributes and the data sources. Is there a rules engine AI tool set to help group things together by category and subcategory? Meaning, how do you might have all the attributes to say these items are considered PPE or these items are considered reagents. How do you help your customers with a rules engine that collects that for their needs?
Yeah, I'm not sure. TJ, if you want to answer anything to this, because I know he's been pretty involved in it, but we do have like a neural network approach, a machine learning approach to take in basically everything we know about an item. So GMDN, descriptions from the manufacturer, descriptions from customers, the approval clearance documents. We take this large piece of all this different text, and perhaps even now the information that was on the label about the item. And then we have a tree structure that is essentially tagging it in terms of a noun type. So what is this item in terms of a clinically friendly way of reading it? So not just like noun, but like actually the type of item. And I think there's some examples in the documents we submitted. And then we look at tying that back to an actual standard. So we don't want to make up our own categories. So while we have that category, we see it as like a way to move standards forward. So I think a good example, if anyone really familiar with like the good ID, was spinal related systems implants. That was a terrible categorization in the good ID. So we had all the types of items for those 100,000 items that we identified the categories and subcategories below that. And we've actually sent that to the GMDN agency, and they've been building out additional GMDN terms because we want it to tie back to a standard that's universally acceptable. So that's kind of some background on what we do and how we think about it.
Okay, thank you.
Yeah, in the latest release, literally this month in November, there were 3 new terms added around that to further break it down.
So with the FDA and the emergency use authorizations, how are you incorporating non-FDA approved product into your search algorithms?
Yeah. As I mentioned, we went outside the FDA. While we have been pulling the EUAs in, we have been pulling other countries' data sets. I think one thing, Canada actually did a very good compilation of all the different N95 masks and specifications. So we actually pulled that. So we've gone outside the normal data sets. The first step we did was all the NIOSH approval database. So we scraped the entire thing regularly now and pull it in. So different data sets. The nice thing about our solution is it's really set up to pull as much information as quickly as possible each night.
Great. Thanks, Rich. Thanks, David.
Thank you, Symmetric Health Solutions, for that innovative pitch. The winning announcement will be made by Scan Health's partner, Next Generation Manufacturing Canada. I would like to welcome Dr. Jason Lyons, CEO of Next Generation Manufacturing Canada.
Well, thank you very much, Ron. It's great to be here. And thanks also to the teams from DEFUSE and Symmetric Health Solutions. Both teams provided a very innovative and very viable solutions to addressing the challenges of the competition. In addition to the video pitches that you saw earlier, the teams were required to submit a full project proposal. Our assessment criteria included feasibility of the solution implementation, evidence of best practice, creativity and innovation, data and information infrastructure requirements, and resources required to support implementation, of course, the scalability of the project itself, of the solution. We were seeking a solution with the capacity to compare product attributes and technical specifications to determine whether a product can be substituted safely and perform effectively in a situation where product supply shortage requires a health system to substitute products from other sources or vendors. Addressing supply shortages and sourcing alternative products has, of course, become especially critical during the COVID-19 pandemic. In addition, the solutions needed to demonstrate that they can share product data in a standardized way to enhance business and care processes and reduce costs for health organizations that are seeking to ensure and provide product-safe PPE to support the health and safety of the workforce. Both of the finalist solutions offer very dynamic and capable ways of transforming your health organization's supply chain into a strategic asset that will allow you to achieve your business needs and your business goals. We encourage you to learn more about DEFUSE's and Symmetric Health Solutions proposals on the Scan Health Knowledge Mobilization platform following the event. But now, I'm really excited to announce the winner of the 2020 Scan Health Design Competition based on Eastern Health's business case. It gives me great pleasure to recognize Symmetric Health Solutions as the winners of this year's Scan Health Design Competition.
Hi, everyone. This is Rich Casera, CEO of Symmetric Health Solutions, and I'm here to say we are thrilled that Symmetric was selected as the winner of this year's design competition. We are grateful for the opportunity to connect with the impressive judging panel that ScanH put together, including Eastern Health, Mackenzie Health, Alberta Health Services, McKesson Canada, the Association for Healthcare Resource and Materials Management, and Next Generation Manufacturing. Our team's efforts to pursue innovation by securing accurate data is rooted in an understanding that the adoption of standards in global health systems will improve performance and patient outcomes, especially during the COVID pandemic. If you're interested in learning more about our company or have feedback on our proposed solution, please don't hesitate to contact us through our website at symmetrichealthsolutions.com or email me directly at rich.casera@symmetrichs.com. Thank you and happy holidays.
Congratulations to the Symmetric team, to Rich, John, Thomas, and Ryan, and their partner Matt from the Resource Group. I also want to thank Randy, Yelin, Julia, and Jeremy from Team DEFUSE for putting forward an innovative solution and engaging with us in the design den. It was a very competitive solution, and we think it would be a great candidate for further development. Thanks as well to all of the teams that participated in the challenge this year, and in putting forward proposals that I think really do offer very innovative solutions to some of the problems that we all face at this time of the COVID-19 pandemic. The full solution proposals are available online at scanhealth.ca. We encourage you to contact the companies directly
about additional information about their solutions and how they support safety, quality, and public health efforts to contain the spread of COVID-19. We now have a break. When we return, Mr. Hal Wolf, President and CEO of HIMSS, will provide our closing keynote.